You look at DSM-1 and DSM-2 in regards to how they looked at substance abuse, it still very much was an issue of morality, of character, really defining people who abuse substances and engage in addictive disorders as deviants, as really these are people who should be held and incarcerated and should not be let out in the wild as they all that obviously changed with DSM-3, 1980, I want to say, where really clear scientific criteria for substance abuse was actually generated for the first time in our nation's history. That's really a pivotal moment in my mind because that's still my lifetime, so that's like 30 years ago, and that's really when people started to say, hey, these men and women that struggle with substance abuse, drugs, alcohol, cocaine, that there's this compulsive quality and that there's a shared common phenomenology that they do that isn't always about them being degenerates or morally bankrupt. Fast forward from 1980 to DSM-4, 1994, where you see a further refinement of that criteria, scientifically more valid, scientifically more sharp, I suppose you want to say. But there's still no clear biomarkers, there's no clear biologically valid things that we were looking at. And so really, as I think about it, and it evolved essentially when I started joining the field in addiction in the mid to late 90s, when through the power of neuroimaging, we were able to show for the first time in animals as well as in humans that there are these brain changes brought about by drug use and drug abuse. And that the brains of patients with addictive disorders looks and functions very differently. I always remember Alan Leshner, formerly the head of NIDA before Dr. Nora Volkow, in the mid to late 90s was saying that there is a biological switch that happens when you use drugs to the point where you go from social recreational use to essentially total loss of control characterized by compulsion, urges, chasing, cognitive impairments. And I remember as a medical student hearing that and thinking, wow, so he's essentially describing what happens to the heart if you eat too much hamburgers and French fries. You eventually reach a part where the heart no longer functions as well. And he was describing that this is what's happening inside the brain of patients who are addicted to drugs. So that's mid to late 90s, but again, the DSM-4 criteria didn't change, even though neuroscience was beginning to show that, even though we had more and more data to reflect that. So at the time when DSM-4 was written, we didn't have the neuroimaging or the genetics or the biochemical markers or other things that we now have more of. The way I think about DSM-5, when it was first in the planning stages over the last 10 to 12 years, it was supposed to be this promise of let's have biomarkers, let's have genetics, let's have predictors of response to medications all marshaled in there as signs that we can use for diagnosis. Unfortunately, that never came to be, and we instead have a more refinement of the psychological and behavioral characteristics of addiction that we will see in DSM-5. So the biggest thing being, and I think this is really revolutionary, is that I went to medical school at a time that substance abuse and substance dependence are seen and characterized as two separate disorders, unique. They're brown shoes versus black shoes. Now what we're doing is folding those two diagnoses together into a single unifying unitary diagnosis, substance use disorder or substance-related disorder, that encapsulates symptoms from both abuse and dependence into a singular diagnosis. Or another way of thinking about it, I think about it, we're taking our brown shoes and our black shoes and we're squashing them together to get a mixed hybrid kind of looking shoe that supposedly will fit ourselves better and will actually give us more of a refinement in diagnosing people. So the thumbnail sketch of that, as I think about it through the history, is going from identifying that these men and women, yes, first are very, very different somehow, but maybe they're different because they choose to be different or they're social deviants, to no, they are psychologically different, but we don't know quite yet now why. Maybe they have themes of wanting to self-sabotage themselves. To now in the mid to late 90s, well, they're starting to have signs that the drugs are changing their behaviors and that they're born differently because they're biological risk factors, to where we are right now in 2013, which is that it really seems like that addiction is a more of a spectrum disorder. It's more on a continuum. It's dimensional. It's not black or white. This isn't like HIV. You have a virus or you don't. You don't have addiction or you don't. You are vulnerable to addiction and sometimes in your life, and other times you're resilient. So addiction behaviors in patients can come and go. It can fade. It can stay quiet. It can spark up very quickly. But at the core of it is that it's still very much seen as a chronic relapsing brain disease for most patients who are addicted. But even those, we now know that there's some patients who can naturally recover, who can grow out of this phase for long stretches of time and never have trouble. So in other words, what we're seeing is that we're beginning to get more understanding of what the term addiction means, and then hopefully in the next 10 to 15 years we'll get some much more clearer biological markers that can help differentiate those who are clearly biologically and physiologically vulnerable to addictions versus those who are just, basically going through a phase and they don't really need treatment. They just need some education and some monitoring and things like that.